Yeah, good morning once again. And once again, I would like to thank the organizers and the chair for introducing me. Um, so, I'm going to talk about the objective measures in auditory brainstem implant. Now, before I open my data, I wanted to declare that I don't have any, no, it's not moving. Yeah, I don't have any conflict of interest. And every data that I present here is all my own data. There's nothing to do with it. Right. Okay, so auditory brainstem implants is basically a bioelectronic device which is very similar to cochlear implant. The only difference between a cochlear implant and the brainstem implant is the electrode shape and the placement. Apart from that, it's exactly the same. There's no difference. But the most important thing is who is a candidate for a brainstem implant. As per Scenario Globe, there are two indications, a definite indications where the cochlea is absent, nerve is absent, where you can't use a cochlear implant, then he is a candidate for a brainstem implant. Probable indicators where you have an anomaly of the cochlea, anomaly of the nerve. So in this case, it's a probable indicators. They may not be the brainstem implant may not be the first choice of treatment. Yesterday in my talk, I was talking about the application of transtympanic EABR in making decisions in patients with gray zone, that is, patients with cochlear anomaly and nerve anomaly for deciding between cochlear implant and the brainstem implant. So I would like to highlight TTABR is an emerging tool for assessing the nerve function in cases of anomalies. Okay. Now, what is the most important challenge for an audiologist is you look at this, you have to place the electrode on the cochlear nucleus. The cochlear nucleus is right here. And this electrode has to sit over the cochlear nucleus completely and covering the entire cochlear nucleus if possible. But accessing the cochlear nucleus is not that easy. So one of the biggest challenge for us is placing the electrode on the cochlear nucleus and make sure all the electrodes which is placed on the cochlear nucleus are stimulating auditory if it is on the cochlear nucleus. So, and the second important challenge is going to be in identifying the electrode which is on the cochlear nucleus and which is outside the cochlear nucleus, right? This is very important. The second important challenge is predicting the stimulation boundaries post-operative. These are the two major challenges as an audiologist in a brainstem implant. Now, why is optimal positioning so important? Unlike cochlear implant, there is no anatomical landmarks for you to reach the cochlear nucleus. So you have to go through the lateral recess. The cochlear nucleus is very well beneath and under, which you cannot see even under the microscope. So the surgeon has to go based on some of the root entry point of the 9th and the 10th nerve. Once the electrode goes inside, then you will have to position it properly. So I will show you in my next slide why the positioning is so important. Right. Now look at this one. This is assuming this gray image as cochlear nucleus. If the electrode is completely sitting on the cochlear nucleus, whichever electrode you stimulate, the patient is going to get an auditory sensation. Now, in this condition, where you have electrode 1 to 6 are on the cochlear nucleus, and these electrodes are outside the cochlear nucleus. So, when these electrodes are stimulated, he is not going to get auditory sensation, he will get a non-auditory sensation. Because just adjacent to the cochlear nucleus, you've got other sensory and motor functions present. So, it's at the same time, when you push the electrode too far, these electrodes, in this condition, these electrodes will be stimulating non-auditory and these electrodes will be stimulating auditory. So what is more important? The more important is you have to achieve this position. But how do you achieve the position? You can't see the cochlear nucleus. So we have to use an objective measure to predict the position of the electrodes on the cochlear nucleus. Now, one of the most common objective measure that's being used in auditory electrophysiology is ABR, auditory brainstem responses. So we know that when you give a stimulus, you can measure the responses up till the brainstem, and it's a very robust procedure. So we're going to use ABR as one of the important tool, as an objective tool to predict the placement of the cochlear nucleus. Now, the ABR is an EABR. It's an electric stimuli, not an acoustic stimuli. There is a difference between acoustic ABR and electric ABR. The electric ABR may vary in terms of morphology with respect to the site of stimulation. I've explained this in detail yesterday. Depending on where you stimulate, whether you stimulate electrically on the round window, the morphology is different. If you stimulate the spiral ganglion cells by putting an electrode inside the cochlea, the morphology will be different. If you stimulate the cochlear nucleus, the morphology will be totally different. So the morphology of the EABR varies from the site of stimulation. So you may not get all the 5 peaks, but you look at this, this is an acoustic ABR. You get 5 classical peaks, you may get even 6 or 7. This is a cochlear implant EABR. This is auditory brainstem implant EABR. So you see the number of peaks vary, the morphology vary. The more you go higher, the number of peaks will reduce, the morphology keeps changing as well. Now, before I give you an insight into these objective measures, let me give you an outcomes, and then I'll try to correlate these outcomes with the objective measures to give you a comprehensive information about why the objective measures are so important. Now, this is one of our preliminary study, which was published in 2019, looking at the outcomes 24 months post-implant. Now, we looked at the scores. These are the measures, and we measured the scores at different interval, and compared to the 12th month and the 24th month, compared to the pre-operative, the results were significantly better in all these measures. Now, this is the LEAK Little Ears Auditory Questionnaire. Out of 10 subjects, 3 subjects achieved auditory performance closer to cochlear implantees or normal hearing children by 12th month. By 24th month, only 2 children were closer to it. Right. This is only the auditory performance, not the speech performance. Now, this is a slide that talks about the channel status. So, out of all these 10 children, there was one child where channel number 7 gave non-auditory sensation. And this non-auditory sensation was persistent for all the 24 months. So, we have to disable this electrode. So, it's very important. You may have to disable electrodes if it is non-auditory and if it is causing discomfort. These are 2 things. But the question is, how do you know it is auditory or non-auditory in a very young baby? The baby cannot tell you it's auditory or non-auditory, right? Some non-auditory sensations are observable. You can see it, the facial twitch. But some non-auditory sensations are non-observable. And child may not be able to discriminate between auditory and non-auditory when the child has not heard any sound since birth. So this is a challenge. I will tell you how to tackle this challenge using objective measures in my later slides. Right. Now, adverse events, yes, in brainstem implant, you can have adverse events, or more adverse events compared to cochlear implant. The worst severe adverse event, one patient died because of acute intestinal perforation, but this is definitely not a procedure or a device related because this happened 6 months after the procedure. And look at the other adverse events. There was swelling over the device site, which was classified as a device related and which was resolved. And 2 patients had adverse events which is not severe, like difficulty in swallowing and fever and cold, and which was resolved. So adverse events are possible, but that can be resolved with a very good team and if you have a good procedure in place. Now, this is a longitudinal study of 48 months tracking 50 ABI children. We compared electrophysiological scores and also the subjective performances. And these scores are measured at different intervals from 12, 24, 36 and 48 months. Now, first let me present the outcome. So, the speech performance were gradually improving for the first 24 months and started plateauing after 24 months. This includes both CAP and SAR score. Now, out of these 50 children, 6 children achieved phrase identification without lip reading. Almost 4 children achieved connected speech, which is intelligible with the listener having little experience of deaf speech. So, these are the best performers out of 50. If you look at the auditory performance scores, out of those 50 children, almost close to 10 children achieved a very good auditory performance score comparable to cochlear implantees by 12th month and by 24th month, and there was almost 6 children who were closer to cochlear implantees and normal hearing subjects. Now, looking at the electrophysiological data, we recorded EABRs in all the subjects, total of 576 electrodes, out of which we could only get responses in 405 electrodes. Okay, and almost 12% of the electrodes could not be tested because of high impedance, and almost 19% of the electrodes we did not get any response. So totally, out of 576 electrodes, we got response in 405 electrodes. And these responses are classified as 5 different morphologies based on the latency and the number of peaks. We tried to see if there is a correlation between the medial and the lateral electrode, but we did not see any correlation in that. But however, these are the 5 different morphologies. You may have EABR with single peak, early latency, single peak, late latency. You can have 3 peaks, 2 peaks, EABRs, and also no peaks. So morphology may vary. Now, if you look at the latency, the minimum, the P1 is 0.6 millisecond and the P4 is 6.77 milliseconds. This is the latency range from 0.6 to 6.77 milliseconds. If you look at the interpeak latency, so if you look at this, the interpeak latency between the P1 and P2 is less than 1 millisecond, and P2 and P3 is almost less than 1 milliseconds. But the interpeak latency between P3 and P4 is more than 1 millisecond. This is what is something very surprising for us. So we predicted this could be a non-auditory. Usually the myogenic responses, non-auditory responses, are little later in latency rather than the auditory responses. And look at the interpeak latency is much higher. So we predicted this P4 could be a non-auditory, and out of the 63 electrodes, we tried to correlate whether these non-auditory responses picked up in the 63 electrodes using ABR is correlating with the subjective non-auditory responses, out of which we could observe observable non-auditory sensations in 25 electrodes, and we could not see any non-auditory sensation in 38 electrodes, though the electrophysiological data shows there is a non-auditory response. Subjectively, we could not see. So which means you may have patients who can exhibit observable non-auditory stimulations, you can see it, and you may also have in subjects where non-auditory sensation is there, but it is not visible for us. So the minimum latency of the non-auditory response is 3.72 milliseconds. So which means any response beyond 3.72 or 4 milliseconds, we can consider as a non-auditory in this case, right? Now, based on the responses, we categorized the zones based on the latency of the responses. If the response is less than 3.5 milliseconds or 3.05 milliseconds, it is auditory response. If the response is beyond 3.75 millisecond, it is non-auditory response. If you get a response between 3.4 and 3.72, there could be a mixed response. There could be an overlap of both auditory and non-auditory, which is possible, which is masking over each other. So, now based on this classification, we will be able to clearly tell which is an auditory and non-auditory based on the morphology and the latencies. And usually the non-auditory responses, you see this is pure non-auditory, is much larger. The myogenic response is much larger than the auditory. And this is a mixed response. You have auditory and also non-auditory myogenic. See, it's always larger and longer in latency. Now, we correlated the outcomes using the ABI. So, we looked at patients in whom we got EABR in more than 75% of the electrodes. And in patients where EABR was present between 50 to 75%, 20 to 60%, and less than 25%. So consistently, in all the patients where the EABR was present in more than 75% of the electrodes, the subjective scores are higher. So EABR is a very good tool to position the electrode on the cochlear nucleus, and EABR is also a very good tool to predict the outcomes. So if you get EABR in all electrodes, the outcomes can be better. If you get EABRs in less than 25% of the electrodes, outcomes are very poor. So, intraoperatively, if you get EABRs in less than 25% of the electrodes, you can take a call with the consent of the parent whether to go ahead with the surgery or abort the surgery. Right? Now, what is the future of objective measures? So, we tried to see if we can find a much easier way, a much less cumbersome way of measuring these responses. The EABR is a laborious process. It requires a lot of equipment, expensive, and it's also time consuming. So, ECAP is a much easier thing which we are all used to it. So, we need to see the application of ECAP in ABI and cortical auditory potentials and FNIRs. So in the next 4 slides, I'm going to talk about the future of this objective measures. So we published an article long ago in very few patients looking at the cortical auditory potentials in patients with auditory brainstem implant. The point number 1, you can measure cortical potentials electrode by electrode, which is possible. And number 2, the maturation of the auditory cortex can be measured using cortical potentials even in patients with auditory brainstem implant. Why is this important? Because the speech perception is very poor in auditory brainstem implant, and the speech production is very poor. But whether the patient is able to hear the sound, whether it is reaching the auditory cortex, whether the auditory cortex is maturing for sound, it's possible to measure using cortical potentials. This is very, very important to counsel the parents, which gives reassurance for us. We correlated the EABR and cortical potentials, and we published a paper where the EABR and cortical potential warrants that the stimulated electrode is on the cochlear nucleus since the end of the auditory pathway is auditory cortex. So it also correlates well. We tried to look at the electrostapedial reflex. I'm sorry, in none of our patients we could measure ESRTs. Even in other researchers who's working on this area couldn't measure ESRTs, except Marek Fulak, could measure ESRT in 10% of the electrodes. And next is electrically evoked compound action potentials. Now, the most important thing is when you measure a compound action potential and you get a response, it does not mean it is a response of the cochlear nucleus. Even if there is any other motor neuron, you give a stimulus, you will get a compound action potential from the neuron. So all the compound action potential that you measure at the level of the brainstem, not necessarily it has to be auditory compound action potential. It can also be a non-auditory compound action potentials. So this was one of the publication in 2019 or 2020, if I'm not wrong, where they commented that it is possible to measure compound action potentials. Just because they cannot confirm it's an auditory compound action potentials, the term it as local evoked potentials, and they could see a good correlation in patients. So what we are doing now is, this is a sample of the first preliminary, but we are doing a large data pool, large data. We try to measure, we are measuring the compound action potential and comparing the compound action potential with EABR and the behavioral responses to see its correlation. So number 1, this is the ECAP measure when you stimulate the cochlear nucleus, and the point is, as the stimulus charge increases, the amplitude is increasing. And you can also see the amplitude growth for increase in the phase duration. We could get good amplitude growth function in electrodes. We also get poor responses in electrodes which is not on the cochlear nucleus or whatever it may be. And the idea is, by stimulating electrode 1 and recording in electrode 2 and stimulating electrode 1 and recording in different electrodes, by comparing the amplitude and the morphology of the responses in these grid, we will be able to come out with an algorithm which will help us to position the electrodes much better in complement and EABR. That was a study we are trying to do now. Because when you stimulate electrode 5 and it is recorded in electrode 4 and it is recorded in electrode 6, which is outside the cochlear nucleus, morphology will be different. But when you stimulate electrode 4 and if you record from electrode 1, in this case, the morphology will be different. So the morphology varies depending on the site of recording as well. So this is an important cue for us to develop an algorithm in the future. And as of now, the sensitivity is 72%, and the ECAP strongly related with the results shown in the behavioral and EABR as well. So to relate to the objective of the study, ECAP is measurable in ABI using standard parameters. Though the sensitivity is only 72%, we need more number of data to validate, which is currently going on. And the last one, which we have just started using, is FNIRS, functional near-field infrared spectroscopy. This is very important because this is not contaminated by your electrical or RF artifacts. So these are the future. I don't have any data to present about it. We are just in the process of collecting data and writing a program on this. So maybe in the next conference, I'll be able to share some of the preliminary data on that. To conclude, ABI is an option for children with cochlear nerve anomaly who do not qualify for a cochlear implant. Outcomes cannot be compared to cochlear implants. The outcomes are quite variable. Apart from other variabilities, intra-electrode positioning is very important for auditory perception, and EABR is a reliable tool. Now, cortical auditory potential is complementary test to EABR and measures the maturation of the auditory cortex, which can also be used. Now, ECAP is a reliable measure in CI. Application of ECAP in ABI will be good complement for EABR in the future. So, the most important for the future is cochlear nucleus ECAP, and FNEARS is an emerging additional measure. Need more data for validation. I would like to thank my team, ABI team, who is working on these projects. And I want to show a small video of the outcomes. It's not playing. Okay, so till the video is ready, I can. So hold on. How do I go back? Yeah, you can play the video. Voice.
E.
Hi. How are you? Okay. What is your name?
Hi, months of the year. Oh, January, February, March, April, May, June, July, August, September, October, November, December.
நீ வரும்போது யாரோட வந்த? அம்மா கூட வந்தேன்.
Hi, Monica teacher. We can take roots, close our eyes, open them, roots. This apple, this grapes, this orange, this banana.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
What color is this? Is this blue? Right. What color is this? What color? Blue. Red. This is green. Okay.
80, 110.
Correct. Super.
Bye-bye. Thank you so much.
We have never would have dreamed about it. So maybe this will also encourage the professionals here that even if you do not see that excellent results or any results for the first or 1 or 2 years, you will still get on the long run better results. Please let us know your experience.
That's my experience. Read that. Just because I cannot make use of the auditory hearing to learn to speak, why should I be deprived from hearing? Look, imagine a child talking to you like this, right? So the most important thing is the language development and speech development takes much longer time in these subjects. The question is the way that they perceive sound is totally different from the way we perceive sounds. And you wait and watch when we get more objective tools to measure, we can see the cross-modal plasticity which is happening, which means when they hear a sound and the sound is not heard as an auditory for them, when there is a non-auditory sensation, and they learn this non-auditory sensation, relate this non-auditory to a sound. This is cross-modal plasticity that happens to them. And all the children, despite they don't have very good performance like cochlear implanters, none of them are non-users of the device. They're all using the device. We did a survey among the parents with respect to their satisfaction with ABI. I'll sum up in one line. I asked them, would you recommend ABI, looking at your child's performance, would you recommend ABI for some other children who was approaching you to ask some suggestions? Everybody said, yes, we will do it. So though they can't speak like us, it does not mean they don't understand what we say. We have not developed enough tools to measure their performances. That's the way I would put it. We need to develop a lot.
Thank you.